Okay, so we're now recording and live on YouTube. So thank you to everyone who's joined. We'll get started in just a few minutes. In the interim, I'll go ahead and start a screen share of our agenda for the day. But again, we will get started in just a few minutes. Hi, everyone. Looking like a couple other people have joined. This is Carly Houchin at KHI. We are currently, the live stream has been launched, so we are currently live streamed and we will get the meeting started right at noon. I'll go ahead and start everyone's lines on mute, but we'll run through introductions at the start of the meeting to make sure everyone can get unmuted and participate throughout. Hi, everyone. This is Carly Houchin at the Kansas Health Institute. Thanks for everyone who has joined. I think I see a few people still in the process of joining, but it is 12 o'clock, so I'll go ahead and get us started here. To start with, I'll provide a brief overview of the agenda, and then we'll get into some introductions so everyone can be sure they know who all is on the line. Also, just before we go into the content of the agenda, wanted to just remind everyone, both working group members as well as the stakeholder list should have received an email with some materials for the meeting today. That included this agenda that you're seeing on the screen share, the charter document for the working group, the crosswalk of existing recommendations from Klrd, as well as a recommendation rubric that we'll discuss later in the agenda. Additionally, for those listening on the live stream, those materials are posted online on the Kansas Health Institute website. That link should be dropping into the comment section or the chat section of the live stream if you did not receive those emailed in advance. So as I said, my name is Carly Houchin. I'm a senior analyst at the Kansas Health Institute. My role in this project will be facilitating some of the working group meetings, helping pull together agendas, supplemental expertise, and really trying to get all of the pieces in one place so our content experts can put forward the strongest product possible to the special committee. So to do that, we'll begin our meeting today with introductions here in just a moment. After that, we'll hear from our partners at the Revisor's Office, a brief overview of COMA and CORA, so the open meetings and open record guidelines that will shape how the group will collaborate. After that, we will briefly discuss some working group process items just to make sure we're all on the same page about the approach the working group will be taking and some of the logistics of what our work will look like between now and early December. when the special committee has their final meeting days. After that, by 12:25, we will aim to get into some topic-specific discussion. So as a reminder, the special committee assigned 4 topics to this working group, the first of which is workforce, then funding and accessibility, followed by community engagement, and then telehealth as it relates to finance and sustainability. So if you're pulling back up the Klrd crosswalk of previous recommendations, those are the topics that along which those recommendations are sorted and then assigned to this group. After that brainstorming discussion, where we will spend some time talking about barriers related to those topic areas, we will pilot the recommendation rubric that's been developed after discussion at the last special committee meeting, when the group really heard a bit about what would be seen as valuable to the special committee in high priority recommendations. From there, we'll have some really brief administrative updates to make sure we have our chair and vice chair assigned for the group, and other minor items, and we will adjourn by 1:30. But to get us started with our first agenda item, we'd like to go around and do some introductions. If you wouldn't mind, in your introduction, if you could share a little bit about your background, some of the experiences that you bring with you to the work of this group. If you could keep those comments around 1 minute, recognizing that could be a challenge. I know we have lots of great content experts with decades of experience in this field, but if you can just briefly share a bit about your background, as well as your answer to this question. So the question being, if recommendations from this group could remove one barrier in the mental health system, what would that be? So really thinking about the concept of removing barriers is something that seemed to resonate with the special committee. So we're going to kick it off by trying to each list one of those that our staff here will document so that we can be sure to circle back to those and address. So instructions one more time, as I think a couple people are maybe in the process of joining, is a little bit about your background in 1 minute or less. And we haven't done meeting commitments and ground rules yet, but I might step in and interrupt if we get too much over that. And then secondly, your answer to the question, if recommendations from this group could remove one barrier in the mental health system, what would that be? So with that, I'll pause and see if we have a volunteer to go first, but from there, I'll just run down the line and call on people. Is there someone who's willing to start us off?
I'll go first.
Great, thank you, Representative.
All right, hi, I'm Barbara Ballard, and I'm from 44th District in Lawrence. I'm a professor and administrator at the University of Kansas, and my claim to fame really is I serve on Social Services Budget Committee. And it's a committee that I've served on for many, many years. And so I'm very familiar with the issues. And I enjoy working on that committee. Obviously, I've stayed on it all these years. And a barrier that I would like to break down is to make mental health services available to Kansans when they need it. And not only through the mental health clinic that we have available, but that especially those that would voluntarily like to get help.
Great, thank you. The next person I'm seeing in the roster of participants here is Don Jordan.
Yes, thank you. I get a quick summary of my background. I'm retired now, but I spent 34 years with the Kansas Department of Social and Rehabilitation Services. Some of my activities that were relevant was 7 years Director of Operations for Mental Health, Developmental Disabilities, 3 years, same job with Child Services, Children's Services. I 3 years Superintendent Osawatomie State Hospital, 1.5 years Commissioner of the Juvenile Justice Authority, and 4 years Secretary of the Kansas Department of Social and Rehabilitation Services. And I think one of the challenges we're facing right now is the situation at Osawatomie State Hospital with the unaccredited beds and just access to beds. It's limited to people when they need them. That's it.
Great, thank you. The next person I'm seeing on the list here is Representative Carpenter. Representative, I think you might be muted there.
Am I unmuted now?
There you go. Now we can hear you.
Okay.
Thank you.
Good afternoon, everybody. Thank you for attending this and being a participant. We, as a legislature, we need your input on these important issues. A little background, Representative Ballard is my right-hand minority leader, and she does a great job, has a ton of institutional knowledge that I rely on all the time. But my deal about this whole thing, and this won't be new to a lot of you that have listened before, is we spend $564 million on mental health in Kansas. I have to question, I'm not against spending money. Many of you know that I will advocate for dollars to be spent, but it makes it a lot easier for the legislature that if we have accountability, measurements, and outcomes. And so through this whole process, that's what I'd like to see is how many people are we serving for that 564 million? How many people, what are their outcomes? Are we making a difference? Money is going to be tight, obviously, and I'm not against spending money in the right direction on good programs, but it's just kind of hard to spend that kind of money and not be able to say, are we really making a difference? So that's where I come from on this. And I think it would make our job a whole lot easier on the Social Services Budget Committee with Representative Ballard. So anyway, that's my spiel, and I'll get out. I'm sure I went over the 1 minute, but anyway, that's rare for me, I will tell you.
Thank you, Representative. Next person I'm seeing on the list for introductions, Charlie Bartlett.
Hello, everybody, and thank you for the honor of being able to serve on this group. I serve as the Director of Adult Services for Klrd's Behavioral Health Services. I started working in the field of behavioral health and corrections back in the very early 80s. I've spent over 20 years in direct services in substance use disorders as a counselor, and have been with the state since 2001, working for behavioral health services. I oversee the adult services for mental health, substance use disorder, and problem gambling, and then also hold a number of the contracts with the crisis centers, et cetera. I also serve as the liaison to the Governor's Behavioral Health Service Planning Council, and so I help coordinate those activities and work with the subcommittees in those various sectors that they cover. And I think if I would like to see one thing accomplished, it is to further develop the access and to limit the barriers for folks that come into the system with multiple disorders. We don't just deal with mental health, we'll deal with substance use disorders, we deal with physical health, and all of that system to be integrated would provide more seamless services, because you can't just treat one and expect the other to do well. Thank you.
Great. Thank you. Next on the list, Connie, is it freeze or fries?
It's Freeze. So my name is Connie Freeze, and I am the government relations individual at Blue Cross Blue Shield of Kansas City. And I have worked on the insurance side for probably 28 years, was around when mental health parity passed, and helped implement that with our company. I think in terms of barriers, what I would like to understand is how can we create a interest in the public the community investors to invest more resources in inpatient or treatment abuse centers. In my area where I live, Wyandotte, Johnson County, there's a community hospital on every corner. There's urgent care on every corner. Nobody seems to be really investing in a mental health facility anywhere. And I think that I'm trying to understand why that's something, you know, why we don't invest more heavily and do less on the medical side, because it seems that we have an overabundance of beds and options, but there just isn't enough on the mental health side.
Great, thank you. Next person, Greg Hennen.
Yes, thank you. Greg Hennen, I presently serve as the Executive Director of 4 County Mental Health Center down in Independence, Kansas. We go from Independence and Coffeyville to the west over to Winfield, Ark City. I've been with the agency a little over 30 years, came in after getting training in clinical psychology and worked as a therapist, and then found out that they didn't teach me much about running a business in clinical psych school, so I went back and got a healthcare administration degree, and then my career path kind of changed a lot more heavily administrative. So I've been doing this job for about 10 years. I'm a representative of the Association of Community Mental Health Centers. And in terms of a barrier, if there's one thing, I would agree with Secretary Jordan that access to the state hospital beds for both voluntary and involuntary is really a huge bottleneck for us in managing people in the community. And if we could wave the magic wand, that's where I'd do it.
Great, thank you. Next, Sarah Furtick.
Hi, everyone. Can you hear me?
Yes.
Excellent. Good morning, or good afternoon, everyone. My name is Sarah Furtick. I'm with the Kansas Department of Health and Environment. I am the State Medicaid Director. I've been in this role since mid-July. Prior to taking over this role, I've been with the state for 16 years now, and my background includes work with the Kansas Department of Corrections and the Juvenile Justice Authority, so kind of a criminal justice background. And then prior to coming over to KDHE, I spent 9 years with the Attorney General's office. By training, I'm an attorney, so I don't have direct hands-on mental health service provision background. But what I hope to gain out of this committee is to listen and learn a lot from the folks who are dealing with mental health issues on the ground. And if there's one barrier that I would hope that one of our recommendations would seek to address, it would be access to mental health care for low-income Kansans. Thanks, Carly.
Great, thank you. Next, I'm seeing William Warrens.
Hi, Will Warrens. I'm originally from Nebraska, came down, got an undergrad degree at KU, met my wife who's from Wamego, went back up to Nebraska, practiced rural family practice for 2 years, doing colonoscopies, C-sections, deliveries, the whole 9 yards, but I found that I liked mental health too much, went back, trained at the University of Iowa, got board certified in psychiatry and child and adolescent psychiatry, and I've been the medical director for the Guidance Center for the last 10 years. The Guidance Center is a community mental health center covering Atchison, Jefferson, and Leavenworth counties. More recently, I have increased my administrative time because I'm behavioral health medical director for Sunflower Health Plan, and my clinical role is currently shifting to the PRTF world, becoming medical director for Kids TLC. So the one, I guess, focal point or barrier or interest I guess I have is how to help the CMHC system as a whole get secure footing for the next 10 years in dealing with the uninsured population, and how we could rationally help to support them in that.
Thank you. And then Senator Alley.
Yes, can you hear me?
I can.
Okay, I can't see you, but I didn't have a question. I've been trying to log on here for just about 5 minutes, so.
We're doing a brief introduction, some of your background that you bring to this topic, as well as if you could remove one barrier from the mental health system through the work of this group, what that barrier might be.
Okay, I've been on the school board in a small community, We did have experienced some mental health issues during the school year with that. And that's basically my experience with that. As far as a barrier, if we look at schools today and look at children today, mental health doesn't go away at 3:30, and it doesn't go away. I think we need to have a plan to address it for all year and all the time, because the kids and the parents probably need some help during time that we're not in a school.
Great, thank you. Now we also have several, well, let me check in. Any working group members that I have missed in the roster for introductions?
I'm Representative Lynn. I am a representative for District 49, which is in Olathe. I am a parent who has a child with a lived experience. And so one of my focuses, which maybe isn't a part of this work group necessarily, is the prevention though. I really liked what Connie had to say. In Johnson County, we've got these little community hospitals everywhere, which is great. But when you are in the midst of a crisis, a lot of parents don't know where to go, where to turn to, especially when you're late at night. And so I would love to be able to see better education for parents to know what to do and to prevent a crisis, but then also what to do when you're in the midst of one.
Great, thank you, Representative. Any other working group members that have not done an introduction yet? Okay. If not, I'd like to quickly introduce the staff that are on the call. We'll be supporting the work of the group throughout. I'm joined by several of my colleagues from the Kansas Health Institute. If you all could quickly unmute yourself and do a brief introduction. Sydney, we'll maybe plan to start with you.
Sure. Hi, everyone. My name is Sydney McClendon. I'm an analyst at the Kansas Health Institute with Carly and others. I helped previously to support the work of the Mental Health Task Force and look forward to supporting the work of this working group.
Great. And Hina?
Hi, good afternoon. My name is Hina Shah, and I'm a senior analyst at the Kansas Health Institute. Previously, I facilitated the working groups for the Child Welfare System Task Force and also the Crossover Youth Working Groups. I am the project director for our KHI team, and I look forward to working with all of you over the next couple of months.
All right, thank you. And Peter?
Good afternoon, everyone. My name is Peter Barstad. I'm an analyst here at KHI, and I'll be helping however I can throughout this process.
Great. And I think we also have a couple of staff people from Legislative Research Department. Dave, would you like to kick off a brief introduction there?
Sure. My name is Dave Fye. I'm a principal fiscal analyst for the Kansas Legislative Research Department and happy to be providing assistance for the special committee.
Then Matthew Moore with the team at Klrd as well.
Yes, Matthew Moore. I'm a fiscal analyst. Look forward to assisting with the team as well.
Great, thank you. And I think that takes us to the team from the revisor's office. So Scott, I'll turn it over to you for a brief introduction. And then if you'd like to go directly into our next agenda item of the COMA and CORA overview, I'd say take it away.
Sure, thanks, Carly. So my name is Scott Abbott. I'm with the Office of Revisor of Statutes. I primarily staff the health and budget committees of the legislature. What I'm about to go through, if you have followed a virtual committee meeting of the legislature since March, will be very familiar to you. But these are some guidelines that will help the working group stay compliant with the requirements of the Open Meetings Act. So due to health and safety concerns, members of the public are not in attendance at this meeting. The meeting is being conducted by interactive communication, allowing members of the public without cost to listen to the meeting using live stream audiovisual broadcasting on the internet. The live stream link can be reached by visiting YouTube and searching for the Kansas Health Institute or KHI live channel. The agenda and documents for this meeting have been provided by the Kansas Health Institute, and a link to those materials will be provided in the comments section of the YouTube feed. Each member of the working group and staff will state their name and title each time they begin speaking or voting so that they can be readily identified by remote listeners or observers. All participants are required to ensure that microphones, phones, or other electronic devices are muted when the participants are not speaking, so that the ability of remote listeners or observers to hear the proceedings is not unnecessarily impeded. Public comment will not be allowed at this meeting. During this meeting, the working group will not recess to a closed or executive meeting pursuant to KSA 75-4319. Each motion, if any, will be clearly stated before the working group votes, and the chairperson will announce the results of each final vote. And a recording of this meeting will be available on the Kansas Health Institute YouTube channel after adjournment of the meeting, so that members of the public can review the meeting that occurred. If there are any questions about that, I'm happy to answer them at any time. Otherwise, that concludes my overview of the open meetings requirements.
Great, thank you, Scott. So this is Carly Houchin again at KHI. So that takes us to our next agenda item, a quick discussion of some working group processes. So as previously noted, the special committee has assigned 4 topics to the working group: workforce, funding and accessibility, community engagement, and telehealth as it relates to finance and sustainability. In order to kind of cover all of those topics between now and December, our pace of work will end up being about 1 topic per meeting, starting at our second meeting. So in order to get through that volume of work, we have some ground rules that we'd propose, or meeting commitments, meeting agreements that we'd put forward for the group. So I'll run through some of those quickly, but definitely these are open to, for edit or additions if there are previous groups in which folks have participated. Yeah, just other rules are welcome to be added, but some that we would put forward would be that we would ask members to come ready to discuss and compromise. So what that could mean is committing to reviewing materials in advance when possible. Acknowledging that in this work, we're looking for consensus rather than competing agendas, and encourage everyone to, be ready to jump in and participate with limited time available. Any dead air after a question asked is time wasted. So be eager participants. Secondly, and this is a ground rule that I think the Mental Health Task Force found particularly helpful, asking folks to keep remarks succinct and on topic. So keep it short, try not to reiterate. Once you've addressed or spoken on a topic, allow others the chance to weigh in before you share any follow-up comments. Again, another ground rule that was supportive to the work of the Mental Health Task Force was, making the commitment to ask questions. So don't hesitate to ask clarifying questions. It'll be important that the group kind of stays on the same page throughout our kind of consensus-based process here. And then the last ground rule or meeting agreement that I have for the group would be the commitment to start and end on time. So I'll get us started right at the top of the hour for each of our meetings, and we'll end us on time as well. In order to meet this commitment, I'll need permission from you all to be restrictive on time in terms of the amount of time for comments, or the amount of time that we have for an activity or topic. And really that's just done with the goal of being able to get to all of the important agenda items in each meeting related to each topic. So I'll pause there. Are there any questions, edits, or additions to that brief list? So I'll also say my facilitation practice is to try and wait 10 seconds after any questions. So I'll hold that space, but not hearing any questions at this point, I will move us on to our next agenda item, which is the discussion of the crosswalk, as well as some additional brainstorming. So I'll give us some instruction here. But want to ask folks to maybe start pulling out the crosswalk of recommendations that Kansas Legislative Research put together. That was shared at the special committee meeting at the end of August, as well as in meeting materials that went out ahead of this meeting. But with this agenda item, we're really looking to hear from the content experts in the room. about barriers that need to be addressed related to the topics assigned to the group. So we're not looking for solutions or recommendations at this point. We're just wanting to make sure we have the barriers identified as it relates to modernization of the behavioral health system. So with that, we'll have timing wise about 10 minutes per topic. So I'll go ahead and I'll set a timer on my phone. But the first topic on the list for the group is workforce. So I'll pose the question, what barriers are not addressed by any current recommendations that should be raised for the special committee to consider?
Hey, Carly, this is Sarah Ferdig. I had a question on the workforce topic, and this is really one more for the subject matter experts in the mental health field, but is there a particular segment of the mental health workforce that the state is really lagging behind on? For instance, do we have too few alcohol and drug counselors? What specific areas of need do the folks on this meeting see Kansas having?
Go ahead, Greg. No need to raise a hand, jump right in.
Just didn't want to step on anybody if they were going to start speaking. The answer to that question, and there are several credentials that we have a difficult time recruiting. First and foremost is psychiatry. I've been advertising for a psychiatrist for 3 years. Have not had a viable candidate in that amount of time. There aren't a lot of psychiatrists out there, at least that seem to be interested and willing to move to Southeast Kansas. So I think there's an issue in terms of just training, how many are coming out of the schools. And then again, whether we can get them recruited or be an attractive enough location. Clinical social workers are another one that is pretty difficult, both in the school system and the mental health system to get recruited. Master's level therapists with any credential, whether that's marriage and family therapy, clinical psychology, community counseling, so forth, are starting to become more rare. Case management, we're doing, and I can only speak for Fork County, we're doing okay, I think, getting case managers recruited. But I'm starting to hear that that's getting a little tighter in terms of finding an adequate number. I don't know if all of that has to do with just those credentials not being out there in the world for us to tap into. I know in Southeast Kansas, we have struggled mightily to maintain our workforce because we cannot seem to pay a competitive salary compared to Oklahoma or Missouri. And so that's really the financing of our system. And Dr. Warren speaks to this periodically. It's not been very well thought out over the last decade or so. And it's put us behind in being able to compete for that workforce that's so important to the business that we do. So I'll stop there.
I'd like to jump in here for just a second. And I agree totally with what Greg said. I just want to say, from my experience, everything he said is a multiple times worse when you get out in Western Kansas. I know at one point, it seems to me, my memory is right, there was one child psychiatrist in the entire area west of Salina. And so, it's that whole hiring credentialed people out in rural areas is a major problem.
This is Charlie Bartlett. I agree with everything that's been said. Number of years I've been in, I can't hardly think of how many different groups and task forces I've worked on trying to look at workforce issues. Rural and frontier areas, as you said, are very difficult, and people oftentimes don't realize we're really dealing with 3 distinct regions in Kansas, with rural and frontier, rural and urban. And then recruiting people into the workforce with the cost of college and then the lower pays that they receive, and especially in substance use disorders, make it extremely difficult to bring and recruit new people in. And I'm not sure just how much true marketing goes on within our school systems to encourage people to come into the field of human services at this point.
Any others interested to respond to Dr. Furtick's question?
I will.
Go ahead.
This is Barbara Ballard, state representative, and I'd like to just comment on that and concur with what I've just heard. I'm a board member of Burt Nash Mental Health facility here in Lawrence, and you know, we have trouble recruiting for psychiatrists too, and we're not far west Kansas, you know, we're right in the middle. So I think it's a bigger problem than people really realize that it is, because we have had a difficult time recruiting for a psychiatrist, and sometimes we end up having to get somebody from Kansas City who comes in order to help us. But I think just recruiting out of school is a problem too, because of what I just heard, that the pay is so low, and they may stay and get the training and then they leave and we have to start training all over again. So that really is a big barrier. Thank you.
Great.
I'd like to follow up on her comment. She's correct, and one of the big issues is around pay. I know dealing with like an Osawatomie, whether it was RNs or whatever, trying to compete with the Kansas City hospitals, we just weren't there. And I think that is going to be an issue that at some point there needs to be an investment and say, you have to pay enough to lure people out to where we need them.
I agree.
Great. Other barriers related to workforce that are not addressed in the kind of existing roster of recommendations? Not hearing any at this point. You know, answers to that question still acceptable, but I'd maybe add one to the table. When we get to the meeting where we're gonna, you know, do our deep dive on workforce, is there any additional supplemental expertise that we want in the room for that conversation? So have a lot of knowledge, a lot of experience of those on the working group, but specific to workforce, or maybe it sounds like workforce funding, any additional expertise that we should have in the room when we go deep on that topic.
Can you hear me, Carly?
Yes.
Barbara Ballard, state representative. When you said expertise, I don't think it fits in that category, but I think we have to look at diversity. And because of just who the people are, there's a lot of people out seeking, but they may not see diverse, not just race, but well, it's LGBTQ or whatever it is. They may not see that and feel comfortable because they don't think the person perhaps understands. So we may talk about that in terms of how do we recruit, but we know pay is a problem, or there's not enough in the diversity categories coming out in order to do it. But in order to be effective, you have to have someone that person who, if I'm seeing, feels that they have a little empathy with me. They understand where I'm coming from. And that's a really difficult area that we don't have enough of.
And this is Charles Bartlett again. I can't agree more with what was just said. You know, people don't realize it, but when you get out to some areas, such as in Garden City and Liberal, there's over 30 different languages spoken in that school district. And you try to recruit somebody that can speak the language to do the services in mental health, substance use, and it's just, there's just not people there, so they try to work on interpretation, and you just don't get the engagement and that you need in that process.
Mm-hmm. So we're at our 1 minute warning on this topic. So I want to pose the question, any additional expertise that we'd want in the room when we're going deep on this topic? Connie, did I see that you were unmuted? Did you have a comment to add here? No, okay.
Oh, I'm fine.
Great.
This time, Jordan, I guess I would like to add this little bit of, I think at some point, it's not so much expertise we need more of, but it would be good maybe from legislative research if they could reach out and get some statistical information, you know, survey mental health centers or whoever, and sort of how many have vacant positions, you know, what are the numbers that are short and things like that.
This is Connie Freeze. I agree. I have no idea in the Kansas City area if we have a problem with the workforce, or if we are the problem. Can you hear me?
Yes, we hear you.
Oh, okay, okay. You know, we spoke earlier of facilities to take care of individuals, but it would be interesting from legislative research to find out if the metro area or the urban areas in general, such as Wichita, have issues securing workforce.
Great. Thank you for that discussion. Moving down your memo of previous recommendations developed by Klrd, the next topic that we'll come to is funding and accessibility. So taking another 10 minutes, let's take a look at those recommendations that have been drafted there. What barriers related to funding and accessibility are not addressed by any of those recommendations that will be important for this committee to consider?
Carly, this is Sarah Ferdig. I have one to suggest. And this is from the viewpoint of Medicaid. So only as it relates to services that are funded by Medicaid. The structure of the state's Medicaid program is under what's known as an 1115 waiver, where where CMS allows the state to waive certain ordinary requirements for Medicaid. However, the condition for an 1115 waiver is that we are subject to what's known as budget neutrality. And the simplest way to explain this is that CMS calculates how much they think Kansas Medicaid would spend if we were not under an 1115 waiver. That's called the without waiver amount. And whatever we spend under our current 1115 waiver has to be less than that without waiver calculation. The effect of that is that Kansas is restricted in terms of what we can do to increase rates for providers from the Medicaid side. Even if it doesn't touch SGF at all, even if the SGF impact is minimal, CMS is still looking at the overall number of dollars that we're spending, and we have to keep it below a certain level. So I think as long as we're talking about Medicaid, or to the extent that we're talking about Medicaid, we all need to be mindful that even if Kansas, even if the legislature and the governor agree, we want to drastically increase reimbursement rates for certain mental health services paid for by Medicaid, it might not be doable based on the constraints that we're currently under our 1115 waiver. So I would be remiss if I didn't mention that we have limited flexibility in terms of what we can do with regard to rates under our current 1115 waiver. Thanks, Carly.
Thank you.
This is Greg Hennen with Fort County. In regard to funding and accessibility, one of the things that in glancing through this, I don't know that it's noted. There is a federal certification or designation that behavioral health providers can get called a Certified Community Behavioral Health Clinic. And it is essentially the behavioral health equivalent of the FQHCs on the primary health side. We at Fort County are just getting familiar with this. We got a capacity building grant, one of 98 across the nation. And I think one of the things that's very appealing to that certification is it can move a clinic from, say, a fee-for-service reimbursement, where there are clearly limitations if it's under an 1115, to a prospective payment. And I think that and that's what Oklahoma and Missouri are doing, which is why they're outpacing us so badly, and workforce recruitment and what they can afford to pay. But the other thing about the CCBHC that's really appealing is it does whole person integrated care coordination. And Representative Carpenter has talked about outcomes. The accountability and outcomes piece of being a CCBHC it's a pretty steep climb, quite frankly. We're just 3 or 4 months into trying to build toward that. But I think that is something from a system reformation perspective that we need to take a pretty hard look at, is what CCBHC status or certification of our mental health system could do for the entire state.
And Greg, to maybe ask a follow-up question there. Could you maybe articulate some of the barriers, just quickly, the barriers preventing mental health centers from becoming CCBHCs?
Well, initially there were only so many slots that the government even made available in terms of pilot, grant dollars or projects out there. And Kansas was not one of the first 8 states to do that. The opportunity that was just opened up at the beginning of this calendar year was for individual agencies to go ahead and apply for capacity building grants. Not that we are a CCBHC, but we have some capacity building to develop the programming for that. And as an individual organization, there were 8 of us in the state of Kansas that applied. Fort County, again, was fortunate to be the one that had that opportunity here in Kansas. But it's really just a federal initiative or program that is starting to gain traction and build, and not every mental health center has had the option to get a capacity building grant, let alone seek the certification process. So it's in its infancy, which is why I think it's not on this list, but it increases accessibility. We have mobile crisis teams that are out in the community. They really focus on eliminating the 4 walls of a clinic and making sure community-based care gets delivered. And there are tons of accountability measures all along the way as to what you're accomplishing with the patient, not just in the management of their mental health symptoms, but in their overall wellness. And I think it's just, like I said, just in its infancy, but it's something we need to look at as a state very hard.
Great, thank you.
And this is Charles Bartlett again. The safety net for our indigent population is the federal block grant that's received for substance use and also for mental health. And the substance use block grant only runs about $12.4 million a year that goes into the system for substance use disorders, and that has been pretty stagnant throughout all my career at that level, and only about $4 million of that goes into the mental health system. And for people who do not fall within the qualifications for Medicaid, especially the indigent male population, there's just no resource for them to get in, or if they qualify for block grant, which is an extremely low level of income, the wait list become very difficult because we just don't have the capacity for the funding to pay for those people to get services. So they're really left kind of out there waiting for an opening when it can occur. And oftentimes the provider operates at a loss when they are taking those funds.
Thank you. We've got about 2 minutes left on this topic. So want to raise the question again. Is there any other expertise that we should have in the room whenever we're kind of going deep on the topic funding and accessibility?
This is Will Warrens. I'm going to put Greg Hennen on the spot. I am very accepting if he wants to be the historian of the funding of the CMHC system. You know, I know a lot of my knowledge comes from Keith Rickard. I could call Keith Rickard to come and talk to the group, but I also trust Greg Hennen with his knowledge. So I'm kind of posing that to you, Greg, about whether you think, you know, it would be good to have Keith come and talk or not.
Well, certainly Keith has been an executive director a lot longer than I have, and he has a very good grasp of what the history of our system has been in terms of how it evolved and kind of how we have gotten to where we're feeling stuck right now. He would be a great resource for that. He's a very good historian, and I think very entrepreneurial. So I would encourage his participation, even if it was just to provide that kind of framework for everybody.
Carly, if I might just comment, I'm not looking at the documents that you're talking about right now, but we do have Cal Kessler down, do we not, for CMHCs?
Yeah, Kyle Kessler is participating in the working group on system capacity and transformation.
All right, but he's in group 3, but in terms of talking about CMHCs, if we're talking about that, will he be giving input since he is the executive director of that area?
I think if that's something the group wants to suggest related to a certain topic, we could, you know, be sure to invite him on the day we'll be addressing that.
Okay, so I probably would do that because, you know, because of social services budget, we have worked very closely with him, and he's responsible for all 26 of those CMHCs in this state. So I think that would be a valuable resource for us because he's intimately involved with that. And he comes to all of social services budget and the legislature and everything else to oversee what that funding mechanism is. And because we're talking about financial. Okay.
Great.
Thank you.
Thank you. Okay, so I don't know if folks heard my timer has gone off. Either Greg or Dr. Warrens, if one of the two of you could shoot me via email some contact information for the additional expert related to this topic. And I'll move us on to the next topic the group has been assigned, community engagement. So 10 minutes on the clock for discussion, same questions posed. What barriers related to community engagement are we not seeing addressed in the existing recommendations if you know, we have the end goal in mind of a modernized system?
I think I would add one. I don't know how available it might be for all areas in Kansas, but for Burt Nash Community Health Center, what we've talked about over a year of how would we bring the services to make the community aware and maybe try to take away some of that stigma that's attached to it where people hesitate to come. And we are running a series in the Lawrence Journal World. And it takes almost like a quarter of the page, but it talks about, are you stressed? Are you worried? It has a lot to do with COVID, but also making it possible that inviting people to participate or come and take care of mental health. The same as the hospital talks about the programs they're offering. We're making the mental health an issue that we should deal with and not be ashamed of and take away that. So it's it's out there all the time. And so we ask a series of questions, and the ad is done in color, and it's really nice. And we have had a wonderful response to that, because I think some people see themselves, are you stressed? Are you fearful? Are you this? And so they may not associate with mental health, but they associate the emotion or the feeling.
Mm-hmm. Great, thank you. Definitely will add stigma to the list of barriers to address. What else is coming to mind related to community engagement?
Well, I guess.
Well, this is Don.
Oh, sorry, go ahead.
Go ahead.
Oh, I was just going to say, I think Representative Ballard had brought up diversity in the workforce. I think this seems to be another place, diversity in the communities. If we're talking community engagement, you know, yes, we have a lot of frontier counties and they are very unique to engage, but we also have some very urban inner city counties, Wyandotte in particular, where, you know, being sensitive to the diversities of the communities can be really important in the engagement.
Great, thank you. Secretary Jordan?
Yeah, this is Don Jordan. I was just going to say I agree with what Representative Ballard said. And I've found in my history that one of the problems of getting community engagement is so much of, especially in the severe mental health areas, severe, you know, psychiatric diseases, that there's a real sort of prejudice, misunderstanding. You know, people don't understand it, and they don't understand that it's an illness, it's not a character flaw. And it's just, it's hard to get people to engage because of their lack of information.
This is Greg, and I would agree with everything that Secretary Jordan just said. It's really fascinating to me. And when we look at the history of community mental health centers, we were started when JFK signed a law that said every county and every state in the nation needs a county mental health department, just like they have the county health department. And we grew out of communities saying, okay, we're going to have this mental health service available. And over time, there has been an interesting kind of divestment locally in many cases. Our county funding, for example, is about 1.75% of our entire budget. Now, it used to be half of the agency's budget, you know, back in the day. Now we've grown a lot. There's a lot of other programs that we're doing, but I say all this because I look at my service to our communities in Montgomery County. If I do a 5-year look back on our medical record and the number of unique patients that I've treated 1 out of every 4 citizens in Montgomery County in a 5-year time period. That's a pretty heavy penetration into the population, 1 in 4. And even in our frontier counties, I'm treating 1 in 6 or 1 in 7 of those populations. So we're accessible. There's a lot of people coming to us, but I get a lot of pushback when it comes to asking for the county funding to participate in the treatment that we're delivering to the uninsured population. And I've had people that are some of those 1 in 4 that protest our existence, if you will. So I think there's a real misunderstanding of what that service is and why it's funded. But I also know that the state statute for local funding participation hasn't changed since it was originated. Counties can give between 0 and up to $2 million in support of mental health. Well, they have the option of 0. They cannot fund this. And fortunately, that isn't happening, but I don't know that maybe the local participation for community engagement and involvement has kept pace with where we need to be and where we're going.
So just to reflect back there, Greg, so then is the barrier that we're referencing here the statute that allows that support level to be at 0?
Well, you know, that's an example of one thing. I just think that, you know, what Secretary Jordan was talking about is people's perceptions of mental health, and whether it is a character defect or whether it's truly an illness that needs treatment and support. And despite the fact that 1 out of every 4 people have utilized our services, they don't, at least publicly, support what it is that we do. And that's just a little bit of a frustration. So there's some stigma there, but I think there's also a lot of a lack of education for that engagement to occur.
Great, thank you. Other barriers not on the current roster of recommendations, or any additional expertise that would be beneficial to have for this conversation?
Can I ask a clarifying question? This is Don Jordan again. I think it's on there, I believe, but I think that there needs to be addressed the whole issue of the uninsured. And I think that expanding Medicaid should be a significant issue we deal with.
Yes, that is an existing, to the clarifying questions, yes, that is an existing recommendation. I don't remember top of mind which working group it's assigned to, but it will certainly be up for discussion there.
This is Representative Lynn. I'd really like to see an increase in the partnership with private organizations in the community, whether it's with, I know AT&T has one here in Kansas City with Believe KC, whether it's with our Sporting KC team, who's also involved in the bullying project, or our teen groups that are throughout the state. Here it's Zero Reasons Why. I'd like to be able to see a collaborative effort between our private organizations who are doing a great job, but maybe there's some redundancy that maybe we can help make it more effective for them to reach people in their community.
Great, thank you. Any expertise that we'd like to invite for the discussion on community engagement?
Perhaps some of the consumer-run organizations around the states who are helping to support those that have severe and persistent mental illness within the communities.
Great. Thank you, Charlie. And if you have a suggestion of a contact there, please feel free to send that to me via email.
I will do that. Thank you.
Great. Okay.
I have maybe a clarifying. Like we have like the crisis, the mental health, the crisis centers, like Leo in Topeka, and I think we have 5, and Lawrence is going to come online in 21 with a crisis center. Do we have anything that indicates just what role those crisis centers are really playing in the state? Because they're really helping in the delivery of mental health services, where with Osawatomie being closed, we haven't been able to do voluntary and all of that, but just how important those crisis centers are for delivery of mental health services in the state.
Great. So Representative, are you looking for an answer to that question from this group, or would you like to cite that knowledge gap as a potential barrier?
I'd like that knowledge gap as a potential barrier.
Great, thank you.
This is Charles Marligan. Senator, I hold the contracts with all of those, and I would be glad to provide any information or outcomes that you would like to see with that also.
Oh, well then let me jump in and say that is wonderful, because I think a lot of people don't realize that if we took those away, we would really have a problem in the state and the delivery of services. So we may pay them a little in order to keep them open, but I don't think we realize how valuable they really are for delivery of service at a reasonable cost, the same as the CMHC. You can do it on a sliding scale, and everybody must be served regardless of ability to pay. So most of them run a bad debt at some point. But I just think those crisis centers are valuable to areas, and maybe that would help a little bit with rural if we were able to get more in that area, which is very difficult to do, because you have to have the county and other people, maybe a bond issue, a referendum or something in order to help. But I just want to focus on how valuable they are to the state so that people know why we are investing in them.
Yeah, those crisis centers are really important to help divert from state hospital. They do tremendous work, and we've got different crisis, I think, capacity throughout our system, but those 5 centers are really helping the state hospital bottleneck a tremendous amount. But I can tell you what, in the last 10 years, we have lost so many community hospital psychiatric units that that's why everything gets funneled to the state hospital, and these crisis centers are needing to be necessary. We lost 47 psychiatric inpatient beds in Southeast Kansas in about a 4 or 5 year time period. And that was 3 community hospitals that had 15 to 17 bed units each that just completely got out of the business. And as soon as those 3 hospitals were no longer a resource to us, we have to drive 2 hours to hospitalize any of our people. And and the state hospital isn't an option for the voluntary patients. So those crisis centers are really critical to keeping people close to home.
Great, thank you. I'll jump in here just in the interest of time. I'll move us on to our 4th topic area. So telehealth. You'll note we don't have any existing recommendations on this topic. So what we're looking to do here is just a pretty rapid initial brainstorm of barriers that this group should address related to financing of telebehavioral health services or the sustainability of offering them.
One of the first things we need to do is look at the access to broadband throughout the rural areas.
Great, thank you, Senator.
Again, this is Charles Bartlett, and I think Greg probably can also attest to this. Because of the COVID and the use of telehealth being so valuable, and there's been some restrictions lifted in the ability to deliver those services through CMS and SAMHSA that have allowed services to happen in ways that we weren't able to do before. We're seeing so much value in those. We're seeing engagement. We're seeing people reach that normally weren't reached. I think one of the things that we want to be able to do is maintain some of the ability to deliver these services that have been granted to us kind of temporarily at this point because of the COVID.
Yeah, this is Don Jordan again. I would think that looking at the people on this group, and I don't want to take anything away from Greg because I have a lot of respect for him, but I think in this discussion, it might help to get somebody from Colby or Goodland, Liberal or something way out there to hear what their perspective is of being able to do it, to access it, how it'd work, and just that extra perspective.
Great. And again there, Don, if there's a contact that comes to mind from one of those communities, please feel free to send that name my way, and I'll be sure that they're included whenever we're discussing telehealth.
Senator Rick Billinger.
I would trust Greg.
Sorry, come again?
Yeah, this is Senator Larry Alley. Senator Rick Billinger was very interested in that topic because he was looking to put 40 beds in Hayes for the youth.
Great, thank you.
This is Barbara Ballard, and I'll comment on that. You know, the one thing, and it might be down there with telehealth, is that if we're talking about the stigma attached, this is one way that can help in that area, because it is a direct, they don't have to, come out or go into a building and everyone in a small community gets to see them, or even in a bigger place, everybody seems to know your business. This might be one way that they're able to get help without worrying about a stigma being attached, and getting the information, especially if they can just log on and see it and not have to be visible all the time. I know it sounds weird, but you know, people want help sometimes, but they're more afraid of the backlash than getting the help.
Thank you. Other barriers that the group should address related to telehealth beyond those discussed, or any additional experts that would be helpful to have in the room, virtually speaking?
This is Jordan again. I just wanted to say what I was trying to say before, make sure it got heard. I trust Greg, and I would suggest Greg would probably have a better idea of who from Western Kansas should participate than I'm familiar with right now.
Got it. Thank you.
If we're thumbs up, okay.
Okay. So check in one last time. I'm not hearing any other barriers that the group would like to brainstorm at this point related to telehealth. That's certainly a conversation that we will continue to have throughout our process here. But not hearing any more at this moment. I'll direct the group to our next agenda item, where we'll pilot our recommendation rubric. I'll go ahead and get screen share started here. But would pose the question to the group of the recommendations on the crosswalk that we were just kind of taking a look at as we were having that discussion. Is there a recommendation that stands out as one that we know we have the expertise in the room that we could use it to pilot our rubric here this afternoon? I'll give you a moment to think on that, and I'll maybe provide a brief overview of what you're looking at here. But that's maybe a question to chew on here for a moment. So what you're looking at on the screen share, and again, should have received via email if you are on the working group or on the stakeholder list, is the recommendation rubric that was adapted after feedback from the special committee meetings at the end of August. So what will happen is we will review the roster of recommendations related to each topic. We'll have that language populated in the top there. We'll have the working group will have a chance to update that based on changes that have occurred in the system or work that's happened in the agency since that recommendation was made. And then in our first pass through the recommendations, we're really trying to do primarily two things. We want to give each recommendation a score on ease of implementation, and that score will be between 1 and 10. And then we want to give each recommendation a score on its potential for high impact. Again, a score between 1 and 10. A recommendation that has a high numeric score is one that we would kind of look at as our highest priorities. So if that helps in kind of thinking what the scale would be there. So what our process would be is we'd first discuss ease of implementation. We'd run through the list of considerations. Those were items that were raised by the special committee. And we're not looking to count check boxes or make this a super technical task. We're just looking at considerations like, will this recommendation require a program change or a program overhaul? And what does that tell us about ease of implementation? And then again, just any notes that we have about cost, as it might be a barrier to implementation, wanting to make sure we're noting those. Making notes if the recommendation includes strategies for continuity. So wanting to make sure we have sustainability considered in the recommendations that are made. And then if any of the mechanisms listed are relevant to the recommendation, want to be sure to note those as well. The example given in the special committee is, if a recommendation requires a federal approval process, we just recognize that that will take longer and include several components outside of our control. Then when we're looking at potential for high impact, again, we're just looking for a score 1 to 10. And some of the considerations as far as our discussion might be around whether it benefits a large population. So I'm not looking to put a specific number on that, just a yes or no checkbox there. And then whether the recommendation will significantly impact any special populations. So some of the special populations that were brainstormed by the special committee are listed there. That list is meant to kind of remind us some of the priority populations, but not limit us. So we can definitely list others, you know, at that others checkbox at the bottom. We can make note of any of those. And then as far as equity as a value, if the recommendation will serve those who have been disproportionately impacted by the issue or by the barrier that we're seeking to address, we'll want to make that note as well, making sure that recommendations are serving those as strategically as possible, in not just making services evenly available, but making them available as needed by individuals. And then lastly, under potential for high impact, we'll be making any notes as to cost savings in other areas that the recommendation might produce. Then our last kind of question in the first pass will be making any notes as to how this recommendation contributes to modernization. That's I think a helpful question to kind of remind us what the task is here. Just thinking about, you know, in a modernized mental health system, what is true in terms of either the scale on which the recommendation would need to be implemented or what have you. So that's what we'll be trying to do in kind of our first pass through each recommendation, is describing it on some of these dimensions and dropping a score on there. When we come back in our meetings in November, we'll kind of be going back through recommendations, making sure we have that strong consensus around how everything is scored. And at that point, we will, where possible, identify kind of who the action lead is. So who's the responsible party for moving this recommendation forward. And as well as listing any key collaborators. So basically, you know, if who needs to be included so that this decision can be made, you know, decisions can be made towards implementation that will, you know, set this recommendation up to be successful as possible. Some of that information exists in previous reports. So by the time we go back through, we'll have pulled forward any of that information where it already exists in an effort to save us some time there as a working group. And then the other item that we'll look at in our last pass is kind of, it's labeled intensity of consensus, but I think this is almost like maybe our gut check question. So regardless of how we've scored these, as we're thinking about, you know, what a modernized system looks like, is there a strong consensus from the group that this recommendation is necessary to modernize the system? Okay. That was perhaps a bit of a detailed overview. Can I answer any questions about the rubric before we maybe take a shot at piloting it?
Carly, Representative Carpenter here. What document were you working off of to have all of these questions? I thought I printed off everything. I was curious if there was another document that I did not have.
This should have been one that went out, the recommendation rubric. Are you able to see it on the screen share right now?
I have that, but I'm talking about for these items that we've discussed and all that, accessibility and workforce and all that. Was there a document for that?
Yes, that was the Klrd crosswalk of recommendations. So that was that should have been included in the email. We can make sure to forward that again.
Was this the 14-page one?
Yes. So it was the one presented on the August 27th meeting, I think, or maybe the 26th.
Okay, so you were working off the one for the recommendations from the Mental Health Task Force.
Yeah, so it was recommendations from the Mental Health Task Force, the Governor's Behavioral Health Services Planning Council, the SU, yeah, okay. So a handful of groups there.
Okay, I just was curious about the questions and how they were addressing them. So, okay, curious. I didn't know if I had a document missing or something. Okay.
Great.
Thank you.
Yep. So as far as jumping in maybe to a brief pilot or practice of using the rubric, is there a recommendation that someone feels strongly we should address first here?
Again, this is Charles Bartlett. When we have the special populations, I'm interested in that they list rural communities and urban communities. They do not list frontier communities. And there's a big difference in what a rural community is and what a frontier community is.
Mm-hmm.
And we have 3 designations of communities in Kansas, and frontier being one, and we have many frontier counties. I live in a rural community. I can go to services within a half an hour. Some frontier counties, they may be 2 hours away from services, and what impacts them is different than what affects a rural community.
Great, thank you. And I think that's an edit that we can make to the rubric. So not hearing an example recommendation, have copied in one here that was developed by the Governor's Behavioral Health Services Planning Council. I'll give folks a minute to read on my screen, and then we'll try and have some brief discussion as it relates to ease of implementation to get a feel for what that discussion could entail. So recommendation is to support initiatives that provide tuition reimbursement for addiction counselors equal to those provided to other behavioral health professionals, as well as support better funding for agencies so the agencies may provide compensation and benefits sufficient to encourage prospective professionals to seek training and licensure. So I won't go kind of item by item, but looking at the kind of considerations listed under ease of implementation, what thoughts are coming to mind for folks there?
This is Senator Alley again. What restrictions would you have on that, as far as do they have to stay and work in the counties or in the cities or in the rural areas for a certain period of time if we are going to give that tuition reimbursement?
Yeah, I think that's something that the group could discuss as they revise the recommendation if there was something specific the group wanted to recommend there.
You know, this is Barbara Ballard. I would agree with that because, you know, if a county or area has gone through the training process and then, you know, and maybe financially help them, and then they're only there a short time and they leave, it's a waste. You know, it's the same as that we do for medical school. You know, the state has a policy that we will pay for them to go to school, but if they give 2 years in a rural area or in an area that is in need of, you know, physicians, because it also includes Wyandotte County now. So I think we should have addressed something so that at least if someone has invested financially in someone, that they get to keep them for a little while. They have an obligation.
Yeah. Looking at some of the considerations under ease of implementation, would making this sort of recommendation require a change to existing programs? Would this be a new program?
New program.
Mm-hmm. And what about cost there? Would cost be a barrier to implementation?
Well, someone's got to fund it, right?
What about the mechanism by which? Sorry.
I think that, again, the funding is not as difficult if we can plead our case. You know, we need numbers and that kind of stuff to deal with the legislature on this issue. But clearly we do that for social workers. We do that for other hard to find professions, and I see no reason, if we get our ducks in a row, that we can't do that for this professional. So
I agree.
This is Senator Alley again. You know, on the Rural Opportunity Zone, they gave a tuition reimbursement if they would come and work in their counties for a certain period of time. This is the same type of program. If we have a need in a rural county, in a frontier county, we could put that back, and that could be part of something that the Commerce Department is already working on.
I agree. This is Barbara.
Great. Thank you. So sounds like this is something from discussion I'm hearing, maybe it would be possible through either legislative session or from Senator Alley's comment, maybe it's something in agency budget development that could be addressed. With some of those considerations in mind, someone willing to toss out a score. If 10 is very easy to implement and 1 is, that's a steep hill to climb, where do we land on this one?
Specifically, which one are you addressing? I'm sorry, this is Barbara.
The recommendation to provide tuition reimbursement for addiction counselors, as well as kind of a dual recommendation here. So as well as funding agencies to allow them to sufficiently compensate professionals seeking training and licensure.
Well, I would say, Barbara, again, I would say 10, because we've talked a lot about we're having trouble trying to get people and keeping them and reimbursing them. So in terms of implementing a program that would help with that, I think it's that important.
Okay, I hear a 10. Any discussion or other numbers to throw out there?
Carly, Representative Carpenter here. The other thing that would be contingent on that is a report from research about how it is nationally. I like to take a look at states surrounding us and nationally about maybe programs that they're using and if they're dealing with the same problems, regardless of what they pay.
Great, thank you. Making that note here. So in the interest of time, I will maybe put a pin in this discussion in terms of you know, kind of piloting the potential for high impact category. Looking at our clock, we've got about 6 minutes before our meeting will wrap here today. So with that in mind, I wanted to then quickly address a few administrative items. The first of which is making sure we have a chair and vice chair for this working group. So in the email that I sent out, I asked for any volunteers, and I heard back from Greg Hennen that he's willing to serve. So thank you to Greg. I didn't receive any other volunteers. So as people are maybe thinking about whether they would be willing to volunteer for this role, Greg, I wonder if you could say anything about what a good matching might be. Like I think we've heard quite a bit about what your expertise is, but if there's any gaps that you feel like you have in your knowledge, that would be good to supplement in a vice chair. That would maybe be briefly good to hear briefly for a minute or two. As a reminder, the kind of role of the chair and vice chair, they may be asked to volunteer to present the work of the group to the special committee. They may be consulted by KHI staff on agenda development or other logistics to guide the work of the group. And then as an additional reminder, the charter did indicate that only our content expert members can serve in this role rather than legislative members. So Greg, anything you can share with the group here?
Well, my only thought is somebody with policy background, in terms of just their history. So Charlie Bartlett and Don Jordan obviously come to mind. They've both got a lot of good history with working with the state and understand how our system has emerged. Dr. Warren's also, in any meetings that I've had, has a very well-rounded perspective of our system and how it works and how it should work, or how it can work in the future. I'm not as familiar with other members on the committee, so I don't know that I can comment, but just in terms of having that background of previous policy and what's been tried, I think that could go a long way for us.
Great, thank you. With those comments in mind, do we have a volunteer to serve with Greg as either the chair or vice chair?
Sure, I'd volunteer to serve with him. But I also defer to anyone else, you know, who would want to as well. But
oh, you know, haven't been in that position. You just pray for a volunteer. Good job. Is it William or Bill?
Will.
Will. Okay.
So I took Will.
Good job. Good job.
Great. Thank you for volunteering there. With that group, we'll consider Greg and Dr. Warrens to be our chair and vice chair. We'll negotiate later who's serving in which role. But yeah, as the group is operating by consensus, we don't need to do a vote on anything. I'll just pause to see if there's an objection. If not, we'll move forward with those volunteers. So thank you both. Okay. So the final logistics item, the next meeting of this group will be on October 1st. That will be our first topic specific meeting. So ahead of that meeting, you'll be receiving a worksheet that has all of the recommendations that have been drafted to date on that topic. And we'll be going through the recommendation rubric, scoring as many of those as possible. There's quite a few recommendations related to each topic, so there's certainly a chance we won't be able to get through all of them, in which case we'll do some additional follow-up in between that meeting and the next one. Speaking of subsequent meetings, in the next week or so, a scheduling poll should go out for subsequent meetings of this group. There will be, so October 1st is kind of this group's second September meeting. Just the way the weeks fell, and then the group there will be a special committee meeting, and then following that special committee meeting, the group has 2 additional meetings in October. So look for a scheduling poll there.
Can I ask a question?
Yeah, go ahead.
I had on my calendar the next meeting was September 25th. Has that changed?
Let me double check. I think finance and sustainability, I have on my calendar that this group's next meeting is October 1st at 8:30. So John, I'll follow up with you so we can figure out where that September 25th meeting date would have come from. But at this point, you should have a calendar appointment for October 1st.
The 25th date was actually scheduled to be our second meeting in Topeka, and then they changed that to the October 5th.
Great, thank you, Senator Alley.
I got it. I found out. I got it. It's October 1st.
Perfect. Okay, so we are at 1:30, and I've committed to end us on time. So the only final item I'll flag for you all. You should have received a handful of emails from me at this point. If I'm not reaching you on the best or most convenient email address, please let me know how I should be contacting you. Additionally, I've heard from a couple of people as to who other staff people I should include to help support them in scheduling. So if you have someone who helps you with your schedule, please also email me that contact information so I can include them when we're doing any scheduling polls or on calendar notifications. With that, unless there's any question, we will adjourn the work of the group for today and meet again on October 1st. Thank you. Bye, everyone.
Thank you, Carly.